Ashley Barrow. You can go ahead and start to take yourself off mute. Your slides look fantastic. You're ready to jump in?
Can you see my video? Okay.
Yeah.
Hello, everyone. Hello. My name is Ashley Barrow. I'm the founder and CEO of Reassist. So I just like to talk about myself just for a minute. I've been a nurse case manager for almost 16 years. And throughout my experience, I worked in hospitals, I worked in a community-based setting, but what remained constant was readmissions. I even helped my family member transition from end-stage renal disease to transplant. And all I would see a lot of the times is people readmitting to the hospital. So the definition of a readmission per Centers of Medicare and Medicaid is unplanned readmission to an acute plan hospital within 30 days of discharge. So to look at this from the care coordinator standpoint of view, we have to kind of look at a case study. So we have a lady here. She has multiple sclerosis disease. She is a maximum assist with all of her acts of daily living, and it has been deemed unsafe for her to go home with services. So she needs to go to some type of facility-based therapy treatment, physical therapy treatment. She will also need to continue her IV medications to stabilize her MS. The oxygen will need to continue. And finally, she has a Medicare Advantage health policy through her insurance that will require a pre-certification. So what happens on the front end is a care coordinator provides a paper choice list to the patient in this vulnerable state. On the bedside, families are acting like pseudo social workers. And on the back end, trying to figure out, where to send their family member. But on the back end, care coordinators are looking at this patient. They're trying to find the best place for them to go to get the best outcomes. This can easily take a half a shift to days to coordinate. And between the other 15 patients on that care coordinator's caseload, it can be upwards of 100 transactions in a shift, looking at electronic health record, talking to doctors, nurses, talking with the family, and also the patient. And to be a good, to help with the good transition and officiate KPIs, that care coordinator may have to recall upwards of 250 service providers and their prerequisites for admission. And this all leads to delays, increased costs, and readmissions, especially for our Medicare patients, who are the most vulnerable. They readmit to hospitals at about 16.9%. That's 2 million patients a year, and that's $26 billion in costs. One of the top 5 reasons for readmissions is previous poor transfer of care. And that's why I created Reassist. Reassist is a software solution that replaces that paperless directory and transfer of care planning. We pride ourselves on helping coordinators match vulnerable patients to the right skilled service providers, resulting in reduced readmissions. So here's how we work. You come in as a coordinator, and we are a marketplace of in-network service providers. What that looks like is a coordinator can come in and filter by comorbidities. They can filter by wraparound services, location, insurances accepted, service availability, location. And then they will get those results in seconds. So that half a shift trying to figure things out can be reduced significantly. And why now? Well, CMS is adapting to a new landscape and is a call to action for, as the Impact Act is asking for more transparency from acute to post-acute care. There's the interoperability and patient final access rule that are making all of these softwares, a lot of these softwares become patient-facing, which is a huge change for the hospital environment. And then hospitals are even being penalized up to 3% of their reimbursement for high readmissions. These policies are promoting value-based care, and that's going to require changes at the systematic level, especially for hospitals. So our market opportunity, we're looking at the referral management market at $6 billion. Specifically for those Medicare patients in transition, that's about, and with the readmissions and the penalties, that's about $320 million. We believe we can get to the $16 million within 5 years by having a $5,000 to $10,000 onboarding fee, and then just charging $50 per coordinator on an annual subscription, per month on an annual subscription. So our ask today is we're looking to open up a round of $1.5 million. We've already raised $400,000. We're looking to build on to our research and development, grow our team, and then also sales and marketing. Finally, we're looking for pilot partners, especially hospitals that are in urban areas. We're looking at those cardiometabolic patients that typically have obesity, hypertension, cardiac effects, diabetes, and to see what it would look like if they had more access to care. So it's a 90-day pilot. We would have a nurse that would enable this technology, and then we would prove those outcomes, or a 6-month opportunity where we would assess KPIs. We will train staff, deploy our platform. We will do benchmark studies. This will hopefully be part of a grant that we're going after through SBIR, and then also complete that phase 1. We have also partnered with Harvard to try to work out validation, outcomes, and measurements of the platform. So we are really capturing everything we need to increase patient interface. With that being said, this is our team. We're diverse in nursing, project management, financing, and healthcare administration, and we're ready to take on this challenge. So what I'd like to do is what I've been doing for the last 16 years of my career, and that's provide a vision around quality during transfer of care. Thank you so much for your time. I'm ready for any questions.
Thanks a lot, Ashley. Fantastic progress that you've made and great presentation. Really glad about this challenge that you're taking on over here. Great solution. Now, first up in our judges here is Vanetta Daniels of KPMG, Director of Healthcare and Government Solutions. Vanetta, please jump in.
I think, Ashley, I really enjoyed your presentation a lot. Very near and dear to my heart. So I had a lot of questions. One, in the healthcare setting, and I actually just came from Grady Health System, integration of a new tool with the 500, with the EMR and other systems that the care team has to go in and out of is often a barrier to integrating these type of new technologies. And so how does this integrate with, either the EMR or other things that are currently in place? And how does this even make that coordination easier?
Yeah, so, okay, there's 2 questions. So how do we integrate with EHR? So with these new rules is a new standard of care. I don't know if you guys have heard of HO7, FHIR, things like that. This new way to tap into technology is going to allow us to get information from electronic health record in a standalone form. We can use it, but still have like demographic information and everything like that the patient and the care coordinator can access. But not only that, we can also integrate. So if a care coordinator wants to use just their regular Epic, we're making sure that we're going to be on the Epic Orchard and that we can integrate right through Epic. So if they get on the screen, it would just be implemented in that. So as far as the second question you asked was, what does this look like for a care coordinator? Well, all that research work in the back, the duplication of services, the rework that it takes to call around and say, hey, we have a patient with MS, they have IV antibiotics or IV steroids that they would have to continue in the facility. Can you take that patient? You may have to call several facilities to figure that out. Or what you can do is send a mass email, a mass fax through Epic. But at the back end of those are salespeople typically that require an incentive to keep their beds full. So as far as quality assurance, what we're doing is we're making sure that the quality star ratings are involved in our process, that care coordinators understand wraparound services. As we're talking through all these wonderful products today, they're consistent with wraparound services that may not even be tapped into or known about through a care coordinator at the hospital level. So we want to be that person to educate that as well, so that those patients with the nuances that need a little bit more help outside of just the transition can have access to that. For example, that MS patient, maybe that patient would benefit from an MS program at the facility, or maybe they would benefit from a brain injury unit if they have lesions on the brain. Things like that is the nuances other than just a skilled facility or an inpatient rehab or so on. So hopefully that answers your question.
Thank you so much, Ashley. Thank you, Vanetta, for your question. Dr. Ngia, can you jump in?
Yeah, thanks so much, Ashley. I mean, you're hitting on a huge problem, and sadly, one that I've encountered more times than I care to admit. I'm wondering, how are you thinking about really carefully proving out your ROI? And, I know you mentioned that you're looking to work with some academic institutions. for research on the back end, but what are you sort of seeing as outcomes that you can show to hospitals and potential clients?
Love, love, love this question, because you know what? Everybody always tells me GI does one thing, orthopedics does another. These different units of the hospital work differently inside the unit. And as a care coordinator of the hospital, when I ran a rehab unit as a clinical liaison, and I would tell you, we had to do at least half a shift of educating the hospital on what floor we were on in the hospital, what we accepted as far as insurance and all those different things. So what we're going to do is make a systematic change, and we're going to flow into every process, every specialty group, and we're going to be able to put this discharge plan in a place where everyone can use it. So that's the first thing. So by doing this systematically, we're going to decrease length of stay. That's a KPI. We're going to increase utilization of providers. So for those coordinators who may not know, exactly what that service offers and the nuances or the wraparound services that carry, we will define that, and we will make it clickable and filterable so they can just easily filter and search through that. Third of all, we're going to decrease readmissions by providing the right information to these care coordinators. So those care coordinators, instead of giving that paper list, they can give a robust list of services in addition to affordability, service availability, and clinical indicators for that patient, so they can choose the best place for them, and they'll have more education per the IMPACT Act. And finally, patient satisfaction. Because we will have more information for those patients at this point of care, their most vulnerable point. We'll be able to provide that education not only to the care coordinators, but the patients will be involved, and their engagement will be increased. So that's how we're looking at KPIs.
Great, thank you.
Thank you so much for your question. Omar, thank you so much for your presentation, Ashley, and all the fantastic work that you're doing.